Assalamu alaikum everyone. Welcome to PSA online lecture series. I'm Dr. Abdullah Nisar, and before we begin, I request you all to mute your mics and keep posting your queries during the lecture in the chat box, which will be answered in the end. Today we have Dr. Faraz Shafiq from Aga Khan University Hospital. Dr. Shafiq is Associate Professor at the department and currently directing the neuroanesthesia services. We will be hearing from Dr. Shafiq from now.
Okay, thank you, Abdullah, and thank you, PSA, for having me the opportunity to present at this forum. So, the topic of my presentation today is anesthesia for awake anatomy. Abdullah, my voice is clear?
Yes, sir, your voice is clear.
Okay, thank you. So, the objective of my today's talk is we'll see what is awake anatomy and the available techniques. We'll see how the preoperative evaluation of these patients is important for being an anesthetist. Similarly, the important analgesic regime of this technique is a scalp block. We are going to touch on that also. And we'll see what are the relevant perioperative complications, what are the beneficial aspects of this technique. And in the last, as Abdullah said, we'll take some queries, and I'll be more than happy to see if everybody would be, the part of this discussion. So it's very important for us. So if we'll see any procedure, any kind of craniotomy has got three phases. So pre-resection phase, resection phase, and the post-resection phase, or opening phase, resection phase, or the closing phase. So if we'll talk about the general anesthesia, all the three phases would be under, definitely into the general anesthesia. But by definition, awake craniotomy means patient needs to be awake during the resection phase, and the sedative techniques varies depending upon the experience between opening phase and the closing phase. So by definition, patient needs to be awake during the resection phase, and it's called awake craniotomy. So yes, patient needs to be awake during the resection phase. And why we want the patients to be awake, during the resection phase, it's just because we want to facilitate for the intraoperative neurological monitoring, and that is the mainstay of opting this technique. So always remember the definition of awake craniotomy. So awake craniotomy means patient needs to be awake during the resection phase. So the technique is not new. So if we'll see the literature, the first case was reported somewhere around 1886 in London at the King's College. And the resection was done at that time for the removal of epileptic focus. So developing countries like us, we are, far behind, from the advanced world. And the first case in Pakistan was done at AQOH in November 2015. And up till now, we have done around, 400 to 450 cases. So the classical indication of this technique is the removal of tumor. Most of the time it's supratentorial lesion from the eloquent cortex. And what is eloquent cortex? Eloquent cortex means the part of the cortex or the part of the supratentorium, which is controlling major body functions like sensation, speech, language, and motor or the sensory function. Similarly, the other classical indication of the technique is the excision of epileptic focus. So these are the two main indications. But procedure can be done as a part of other techniques like for deep brain stimulation for severe Parkinson disease. Similarly, it can be a part of chronic evacuation of chronic subdural hematoma. And we have done, the awake craniotomy for superficial AV malformations and the superficial meningiomas. But these are not the, classical indication of a technique. The classical indications I have told you, the lesion near the eloquent cortex and the epileptic focus. So the techniques are very variable. So yes, we have discussed that patient needs to be awake during the resection phase. So the pre-resection and the post-resection phase matters a lot, and the techniques for those phases, it's really variable. And it all depends upon the resources, experience of the team, the confidence level of the team, and overall there is no consensus or preference of one technique over another technique. So the available techniques are either a sleep awake, a sleep technique, a sleep awake, awake technique, or the awake throughout approach. So there are three techniques. So this is a survey about the preference of anesthetist for the awake craniotomy. So the survey was done in the England. So the preference were the most of the time the preference was for sleep awake sleep technique. Awake throughout approach was used for around 30% of the patients, and a sleep awake technique was again it was around 30%. So there is no preference of one technique over the another technique. So anything can be used depending upon the experience, confidence level, and the the available resources. It's very important. Similarly, for the so for interest, so we have to be relying on certain agents for keeping patient awake during the resection phase, or for the intermittent sedative techniques. So the available agents are either propofol, dexmedetomidine, remifentanil, and the remimazolam. So one has to use these agents depending upon the technique, and most of the time during the resection phase. So these are some available agents, and we all are familiar with that. So the problem with the agents like propofol, remifentanil is the respiratory depression, the incidence of which is around 10%. Similarly, the use of propofol and remifentanil has been associated with the desaturation, hypoventilation, hypercarbia, and ultimately both of these things like hypoventilation and hypercarbia can lead to raised in intracranial pressure. Similarly, with the drop in the GCS can end up in having aspiration and disorientation. So these are the common problems which are mostly associated with the use of propofol and the remifentanil or any sort of narcotic if one is using. So these are the very important side effects, and ultimately, we might end up in having, adverse consequences. But the recent, so the with the recent implementation of dexmedetomidine, so the role is well established in neuroanesthesia nowadays, because so one of the most important thing, if whether you are using it as a part of general anesthesia or as a part of awake craniotomy, so the incidence of post-operative cognitive dysfunction would be really low. Similarly, it provides quality analgesia. And the most important thing that makes it, different from the propofol, remifentanil, or other sedative agents is the sleep induction. It activates the sleep induction pattern. It's called collaborative sleep induction. It means it activates the normal sleeping pathway of the patient. So when the patient would be awake or patient would be recovering from the effect of dexmedetomidine, so it would be like patient is awakening from the regular sleep. Similarly, the other beneficial aspects in terms of cerebral blood flow and autoregulation. So it has got minimal effects on both of these things. Similarly, with the use of dexmedetomidine, not I'm talking about the awake thing, but as a part of the craniotomy, you can achieve inhalational sparing effect, and we are all familiar with the harmful effect of inhalational in terms of increasing cerebral blood flow and the ICP. So you can spare those kind of the effects. So the use of dexmedetomidine it's quite logical. It's and nowadays it's very well established. Similarly, the upcoming agent is remimazolam. So it has got the properties of both the remifentanil and the midazolam. So it's been recently implemented. It's a benzodiazepine acted through, and the mode of action is through the activation of GABA inhibitory pathway. The role is emerging for neurosurgical procedures, and its pharmacological properties include its ultra short acting, it has got rapid elimination, it doesn't affect respiratory rate, heart rate, or the blood pressure, and the metabolism is ultra fast, which is being done through the tissue esterases. So the remimazolam. So the only problem nowadays from our part of the world is the cost, and it's not readily available even in the advanced healthcare setups. But yes, lot of literature is coming up with the use of remimazolam for the techniques like which we are discussing right now. We cannot be. So this was a recent narrative view which was published in Journal of Neurosurgical Anesthesia. It is one of the the most renowned journal of the neuroanesthesia. So the role of remimazolam in the neurosurgery. So they have explored so as per this narrative review, the indications are well established for neuromonitoring, for awake craniotomy, so indication of remimazolam. Similarly, it can be used as a part of other neurological disease. So it has got beneficial impact in terms of cognitive impairment, and it has got definitely a neuroprotective role. And with the bolus dose of 0.1 mg per kg, the onset of action is within 30 seconds, and the peak plasma concentration one can achieve within a period of 1 to 2 minutes. Similarly, the peak effect of the sedation would be like for in 1 to 4 minutes, and once you stop it, so after stopping it, the patient would be fully recovered within a period of 10.5 minutes. So these are the huge advantages if we are talking about patients having awake craniotomy or any sort of neurosurgical procedures which we are proceeding with the intermittent sedative technique. So this is very important, so for all of us to get understanding about the remimazolam. So the approach which we are using at our hospital and which I want to discuss with you people, so it's called awake throughout approach. So it means patient needs to be awake. Patient would remain awake throughout the pre-resection phase, resection phase definitely, and in the post-resection phase. But yes, we have to provide them with the adequate comfort level through the conscious sedation. So patient though would remain awake, but the conscious sedation would be managed through the use of dexmedetomidine. So first thing first, so the awake anatomy starts from the patient selection. Selection of the patient is very important, that in which patient's population or what type of patients you are dealing with. So most of the time, the selection is by the neurosurgeon. And the classical indication is lesion lying near eloquent cortex. So that lesion needs to have a straightforward dissection, minimal chance of bleeding, and in terms of complexity, reasonable surgical duration time should be there. So all these things can be, go ahead with the, awake anatomy. So these things needs to be considered whenever, you are selecting any patient for the technique. Similarly, being an anesthetist, it's our job to see that, so okay, surgeon have selected the patient. It's our job that you will see that whether this patient or any selected patient can go ahead with the technique safely. And most of the time it requires, liaison with the surgical team. Similarly, as a part of preoperative assessment, we need to see that we have to educate our patient. So the patient needs education in terms of realistic counseling, counseling about the sequence of event, counseling about the anticipated complications and associated discomfort. So all these things needs to be discussed with the patients at the time of preoperative assessment. Similarly, preoperative psychological preparation is also very important, and various things have been proposed in the literature. Just so for say educational brochure, preoperative, theater visits. Similarly, preoperative, the video sessions, and and also discussing with the patients who has got through the similar technique. So these are all the recommended strategies which one can use depending upon the scenario, depending upon the availability in their particular setups. And lastly, it's also very important that by the end of the preoperative assessment, you have to see whether your patient is willing, whether the willingness is there from your patient side for the technique, and if he's motivated or not. It's very important. So for say, if patient is not willing, if patient is not motivated, there is no point for, to push your patient for the technique. If they are not willing, okay, go ahead with the general anesthesia rather than, being push them for the technique. It's not good. So at the end, it's important that introvert. So after discussing with the patient, after doing the careful selection of the patient, so you have to see that during the intraoperative. So what are the intraoperative goals? So most important intraoperative goal is patient needs to be awake. Patient needs to take active part for the neurological assessment. So he or she can do the neurological stuff. Similarly, it's our job to make our patient comfortable during the resection phase and also during the other parts of the surgery. Similarly, we have to facilitate for the cortical mapping. We'll see in our upcoming slide that what is cortical mapping. Intraoperative neurological monitoring we have discussed. It's also important that we have to provide them with adequate analgesia intraoperatively and also definitely to the postoperative period. And more importantly, we have to prevent and treat the common associated complications, which are intraoperative nausea, vomiting, pain, and the seizures. So these are the broader intraoperative goals for any patients having awake anatomy. So psychological preparation. So as a part of anesthetic assessment, it's very important. And once you start doing it, you'll see it's pretty easy from the after getting some experience that you'll see, or you can judge like any other regional technique. For say you are planning any case for any procedure under regional anesthesia. So you have to see, I think it's pretty clear from the anesthesia side, most of the time you can predict that whether this patient can go ahead for the regional technique or not. So same goes for the awake anatomy patient. So after doing the preoperative teaching, after discussing the side effects, associated discomforts, and after telling the patient why it's important to be awake, so you have to assess the motivation. And lastly, you have to declare whether this patient can go safely for the technique or not. So most of the time, I discuss with my patients that if you'll be having general anesthesia, two teams would be working, anesthesia and the surgeon. But if you'll be awake, it means three teams are working, you, me, and the surgeon. So you have to take active part in your care plan. So it works so most of the time it works very well. So patient gets and understand that they are going to participate and they are going to you know help themselves in terms of the resection of the lesion. So this is a just to give you an example. So we have developed this patient education brochure, which we usually, so it's available in Urdu and English, and we hand over it to the, either in at the time of their preoperative assessment or in the surgical clinic. If missed, we can hand over this to our patients at the floor by the preoperative residents. So it works very well. It works very well. So what are the contraindications? So first, the absolute contraindication is patient refusal. Your patient is not willing for the technique, so please don't push your patients for the technique. Similarly, at times, extreme of ages is important because of the issues related to the understanding. Similarly, if patient is having severe COPD, cough, they can't lie flat, and they have got severe cough or sputum and all those kind of things. So these are all the relative contraindications. Similarly, if patient is anxious, panic, has got history of some sort of any psychiatric disorders, so these are not the good candidate for the surgery. Similarly, if they have got some learning disabilities, problem with recalls, memory, problems with aphasia or dysphasia, so these are all the relative contraindications to the technique. But yes, the absolute contraindication is patient is not willing for the surgery. So the classical, in its classical form, the mainstay of analgesia for the awake craniotomy or any sort of supratentorial craniotomy is the skull block. So what is a skull block? It's a field block or the ring block of the skull. So through this block, we target individual nerves and we target those nerves through the anatomical landmark technique. And the local anesthetic admixture one can use depending upon the availability of agent. One can use ropivacaine, bupivacaine, lidocaine, and the commonly used additives are dexamethasone and epinephrine. But yes, because the ring block requires a lot of local anesthetic in a huge volume, so it's mandatory to mix epinephrine with it. So don't use it without epinephrine unless you have diluted it to a strength of 0.25%. So a scalp block, it's simple, easy to perform. It has got very low risk of complication as most of the nerves are the terminal endings. So the chances of nerve damage or any sort of sensory or deficit would be very, very low. And the most important thing, the kind of analgesia you can achieve through the scalp block is it's quite extended. So the in comparison to the local infiltration, which usually the surgeon do, so the effect of scalp block remains there throughout the perioperative period. And it significantly reduces the opioid and inhalation requirement in case of general anesthesia and the requirement of opioid in case of awake craniotomy. So there are a lot of beneficial effect of the scalp block. So these are the commonly supplying, so these are the nerve supplies which we have to target. So the scalp is supplied by the anterior, so the nerve supplying the scalp is the anterior scalp, lateral, and the posterior scalp. So the anterior scalp is being supplied by the supraorbital, supratrochlear. Lateral scalp is by the zygomaticotemporal, which are and the auriculotemporal, which are the branches of trigeminal nerve. And the posterior scalp is supplied by greater occipital, lesser occipital, and the greater auricular nerves, which are the terminal branches of the cervical nerves. So just remember the nerves because you have to target these nerves through the anatomical landmarks. So these are the injection points which one can target as a part of scalp block regime. So before doing any procedure or any sort of scalp block, it's important that you should standardize your drug. You need to calculate the total amount of local anesthetic being used, admixture. Similarly, you have to calculate the safe dose and then you have to proceed accordingly. So make sure things needs to get prepared before doing the scalp block. And similarly, the provision of general anesthesia and the monitoring stuff would be there before going ahead with any kind of scalp block. So these are so this table is just to give you an idea that how we are going to target the individual nerves with the amount of local anesthetic. So it's not mandatory that you have to use the fixed amount of volume. It's just to give you a suggestion and just the basis of which is our experience and what we have learned from our colleagues in Milwaukee. Yeah, so individual nerves needs to be targeted with the individual amount of local anesthetic, and these are the anatomical landmarks. So I'll show you the anatomical landmarks in upcoming slide. So these are the landmarks. Supraorbital ridge is the landmark for the supraorbital nerve, and medial to that would be the target point for supratrochlear nerve. So this is the landmark for zygomaticotemporal nerve. This is a landmark for auriculotemporal nerve, and these are the landmarks for greater and lesser occipital nerve. So for all these injections, you have to be really perpendicular. You have to touch the periosteum and then pull back your local anesthetic needle and have to do subcutaneous infiltration. So as the nerves, as the scalp is supplied, the vascular supply of scalp is huge. So you have to be very cautious in terms of injecting either into the artery or into the vein. So aspiration is mandatory before doing any, injection. So you have to be really cautious in terms of intravascular injection. So as I've told you, the technique is pretty safe, easy to perform. It has got very low risk of complications, and one of the anticipated complication which we all needs to keep in our mind is the local anesthesia toxicity, and the other commonly associated complication is the facial nerve paralysis associated with the auriculotemporal nerve block. So most of the time, so for for the prevention of facial nerve paralysis, so your injection to the auriculotemporal nerve has to be, above the tragus, and the volume of local anesthetic should be, less than 3 ml. So if you'll go beyond the, if you'll go, beneath the tragus, if you'll use a local anesthetic volume more than 3 ml, so definitely you are going to have this paresis that would last somewhere around 6 to 8 hours, and then it start getting settled on its own. So these are the, common complications which are associated with the scalp block. Similarly, as we have discussed earlier, so the area of scalp is highly vascular. So whenever you are injecting any local anesthetic, so you have to mix it with, so first you have to mix it with the epinephrine. Secondly, you have to be very cautious in terms of aspiration while before doing any injection. So after doing that injection, so many studies have shown that within a period of, if you'll see, so the plasma concentration is 2 microgram per ml within a period of 10 to 20 minutes. So this is almost touching to the toxic level. Toxic level is somewhere around 2.5 to 3. But you can see that within a period of 15 minutes, your after doing the scalp block, so plasma concentration is around 2, and then it start decreasing gradually to the safest level after 120 minutes or so. So it's very important for us to understand that that would be the time where you have to be really alert in terms of detecting or predicting any sort of local anesthesia related complication which can occur. Similarly, so this was the case series where they have inject the ropivacaine for different patients, and again the peak plasma. So that graph was for the bupivacaine, and that is about the ropivacaine. So peak plasma concentration is 2.5 most of the time, between 1 to 2.5 within a period of 15 minutes. So so we all have to be really alert in terms of having or anticipation of having local anesthesia toxicity. So that needs adequate monitoring, and all the equipments for resuscitation needs to be available before doing the block. So we'll commonly mix dexamethasone. I'm sure you all must be aware that the addition of dexamethasone to any local anesthetic regime would enhance the quality of the sensory block and causes the reduction in post-operative or perioperative pain score. So after doing the scalp block, now it's a time to start doing the cortical mapping. Before that, you have to make sure that your patient is comfortable, and your patient, he or she, has to be in that position for a duration of a surgery. So the way out is, so after doing the position, just ask the patient that he wants any additional padding or support, or what sort of comfort measures we can take at that time. So it's very important. Please don't push your patient for a technique, for a position which is associated with the discomfort. That includes putting additional pillows under the knees, hands, and sometimes the application of analgesic balm or so that they can have better tolerance with the technique. So the next important step after starting the craniotomy, so once they have done with the craniotomy, they have removed the dura, is the identification and the localization of the lesion. So that is mostly being done by the cortical mapping. So cortical mapping means they are marginalizing the lesion. So how they are going to marginalize it? So it can be done through the electrical stimulation, and that electrical stimulation creates a lesional effect. So after doing that, so with that electrical stimulation, so so wherever the lesion is, for say the lesion was near to the motor cortex. So by the doing the electrical stimulation, your patient was doing the motor task, and once you stimulate that, so patient stop doing this. So it means you are at the lesion. So that's how they are going to marginalize the area of their resection. Similarly, so they do it by the bipolar electrodes. So that's how they are going to marginalize the area that they have to resect this area, and beyond that, they are entering into the neurological tissue for say motor cortex or sensory cortex. So that's how the neurosurgeon marks the area of resection. So the most important part of the technique is intraoperative neurological monitoring. You'll see. So you see, so how important that your patient should be, exposed to you. You should have, adequate or easy approach to your patient. Similarly, patient comforts needs to be there so that he can play his role as a part of, neurological monitoring. So the technique is quite valid for wide variation of population. For say, we have done cases for patients having language barrier, different educational and social backgrounds, economical backgrounds. Similarly, so we have done these cases for different comorbid conditions like hypertension, diabetes, ischemic heart disease, asthma, obesity, pregnancy, patients having sleep apnea. So yes, similarly like metastatic lesions, recurrence tumor, lungs mets, and so yes, so the purpose of sharing this slide with you people is that that technique is quite valid depending upon the resources, depending upon your local experience. And I think few days back I have done the awake cannot be in a patient having huge thyroid swelling and having difficult airway also. So, but yes, we were able to manage to with the awake throughout approach. And for that patient, the lesion was bit superficial. The resection was pretty straightforward, and we didn't use any sort of narcotic to make her respiratory status bit down. So that was the awake throughout approach, and that was quite useful for patient having thyroid swelling. And similarly, we make her position like that because so there should be minimal compressive effect on her anterior neck as a part of her thyroid swelling. So yes, so the quite technique is quite valid for a wide variety of patients. Similarly, the commonly associated complications. So what are the common complications which are associated with this technique? So first thing first, the pain. So the most of the time, so the our scalp block covers our scalp block covers well the the skin incision, and the most of the time the craniotomy. But yes, once they open up the dura, so the dura needs to get infiltrated with the local anesthetic. So most of the time, so the pain arises from the dura. So the way out is to put some local anesthetic patty over there to provide them with the pain relief. And depending upon the lesion, most patient may feel mild to moderate pain during the resection. As I've told you earlier, so it most of the time it arises from the dura. So and this pain most of the time it's transient in nature, and it settles on its own. We'll see how we are going to manage that pain in our upcoming slide. The other commonly reported complications are intraoperative seizures. The incidence is around 10%. Vomiting, the incidence is again 10 to 15%. So most of the time, so vomiting is not there, but any sort of tumor which has got intraventricular extension. So for those kind of tumors, you have to see that you might end up in having a lot of vomiting. So the tumor having intraventricular extension or bleeding. Similarly, the chances though with the monitoring stuff also, that again there would be chances of having neurological deficit. Even we if we are opting the wake technique, so chances of having intraoperative neurological deficit would be there. Anxiety or some sort of panic attack and the conversion to general anesthesia. So these are the commonly reported complications which can occur as a part of awake craniotomy. So this was the study published a few years back in the Europe, and the incidence of respiratory depression was 18%. Similarly, loss of patient cooperation 4%, vomiting 4%, seizures 11%, and the very low chances of having air embolism. So the loss of patient contacts or the cooperation was more with the use of propofol and the remifentanil. Similarly, the incidence of respiratory depression was more in patients having the patients whose sedation was managed by propofol or any sort of narcotic like remifentanil. So if we'll see our local data, so this is the data from our hospital. So the incidence of vomiting is around 0.4%. the intraoperative stuff. Similarly, the incidence of intraoperative seizure is 7.3%. Conversion to general anesthesia, very low. So that study was published, I think, somewhere around 2017-18, and still to the date, the incidence of conversion to general anesthesia is very, very rare. So only 3 to 4 of our patients required, conversion to general anesthesia. Similarly, the incidence of anxiety was around 2%, and the facial nerve palsy was around 2%. So that was the incidence of our local population. And this article was recently published in I'm not recalling the journal name, but yes, it's a recently published article. So again, I just want to tell you that the incidence of delayed awakening. So the incidence of headache is around 14%, nausea, vomiting 3%, seizure 2.3%, and these are the related complications: hypotension, hypertension. So technique is quite safe in terms of hemodynamic fluctuation. But the good thing is that most of the serious complications recovered, around 100%. For say headache, 96% patient would recover, nausea, vomiting 100% recovered, epileptic seizures during the intraoperative phase, so 100% of these patients were recovered from that. So yes, so that was all about, to share with you that so what are the common incidences and the resolution about those kind of problems. So how you are going to manage the intraoperative pain? So the intraoperative pains, the management, so the pain related to the dura. So at the time of opening up the craniotomy, so the dura needs to be, soaked with local anesthetic patty. Besides, during the resection phase, so the reported technique is to inject some local anesthetic directly into the dura. Similarly, for awake throughout approach or any kind of sedative approach, one has to use dexmedetomidine. So when we started our services back in 2015, so dexmedetomidine was not available. But with the recent implementation or the availability of dexmedetomidine, it works very well, and I've seen massive reduction in terms of discomfort and the pain as a part of the technique. So yes, so better to use dexmedetomidine intraoperatively. Similarly, as I've told you earlier, that most of the time this pain is transient and it's settled on its own. But at that time, it's very important that one should be, a person should be sitting. So most of the time, any surgical resident or anesthetist should sit with the patient and do the positive counseling. So it's also very important that in advanced healthcare setups, so the neurological monitoring is being done by the neurophysiologist. So the availability of neurophysiologist, if the resources are available, so unfortunately not available to us, but if the resources are available, so ideally neuropsychiatrist should be, sitting up with the patient for any sort of, neurological monitoring and such kind of counseling which we are discussing right now. So positive counseling works very well, and at times I've seen personally that distraction technique works very well. So just involve the patient in some discussion, sort of things like what's your name, what you do, so what is your profession, what about your kids, family. So all those kind of things works very well in terms of distracting the patient from the surgical pain. Similarly, what about the seizures? So the incidence of seizures is around 10 to 15%. So the seizures. So the most important aspect of managing seizures. So first of all, you have to take the history, you have to evaluate the patient and prescribe them with preoperative anti-epileptics. So it's very important to start any sort of anti-epileptics depending upon the what are the choices from the surgical side. But yes, patient needs to be on anti-epileptic preoperatively. Then you have to, at the time of operative assessment, you have to discuss with the patient that what kind of seizure you will be having. So most of the time your patient would tell you that either he or she is having isolated seizure or some sort of absence activity. So that is very important for us to understand that what kind of seizure usually patient will be having. So that is important in terms of managing the intraoperative seizure episode. So if it occurs, so just
Dr. Faraz, can you please unmute your mic? We can't hear you.
Okay, now it's clear.
Yes, we can hear you. Thank you.
Okay, so the management of anti-epileptic starts right from the preoperative period, where you have to assess the patient what kind of seizure he is having, either is generalized, tonic-clonic, isolated, or absent seizure. And the best treatment is just start anti-epileptics preoperatively, and in the intraoperative phase, the treatment of intraoperative seizure is to insufflate ice cold Ringerlec to the brain matter. What it causes the massive reduction in CMR O2, and it stops seizures immediately. So yeah, definitely. So at times it really depends. If not, you have to use any other form of anti-epileptics, and conversion to general anesthesia really depends on the kind of seizure. But I've never come across with a scenario where I have to convert it to general anesthesia with the seizure activity. So what is well proven? So why we want to opt this technique? So it's well proven that the technique provides you with the optimal resection. So if we'll see our local AQ data, so surgeons were able to do the gross total resection in 53% of cases, and it's very important that the maximum safe resection, if so, it has got the outcome benefit if you resect the tumor as much as you can. Similarly, maximum safe resection was done in around 34% of the cases. Near total resection was done in 7.3% of the cases. So yes, so what is well proven that if you are going to opt this technique, you can do optimal safe resection. And what is that? So you do the resection with minimal neurological deficit, and you can improve the quality of life in terms of preventing, neurological post-operative neurological deficit, and also the disease recurrence. So, so yes, so as I've told you as per our local data, so most of the studies have shown the significant beneficial effects in terms of gross total resection by doing the awake canal. Similarly, you can reduce the chances of having neurological complications, and you can improve the survival benefit. So you can prolong survivals by doing the maximum safe resection. So the beneficial effect lies towards maximum safe resection, minimizing neurological deficits, and prolonging the survival of your patient. So yes, so by doing that, you preserve the quality of life and minimal recurrence. And the last thing is very important. It's not only the recurrence, it's also about minimizing the anaplastic transformation, especially if we are talking about low-grade glioma. So once you take the lesion out, you will do the maximum safe resection, you'll reduce the chances of conversion into the anaplastic transformation, which is, it's a common association with the glioma. Similarly, if we'll see the beneficial effects of awake craniotomy, it's in terms of reducing the length of stay of your patients. It has got cost benefit. It reduces the cost related to the operating room, drugs, radiology, laboratory. So it reduces. So most of the studies have shown that it has got beneficial effect in terms of reducing the cost related to the surgery. That was all about the presentation. So I think it's time for having some questions and the queries and the discussion. So thank you. That was all about from my side. So yes, okay.
Thank you very much, Dr. Faraz. So we do have questions. The first question is with regards to dexmedetomidine, its dose, its usage, its concentration being used during the case.
So yes, so see, it all depends. So what sort of infusion device you have got. So it's available in 200 to 200 microgram solution. So we made it like 10 mics per ml in 20 ml syringe. So the infusion doses. So you have to. So we don't prefer to give any bolus. As you'll see and go to the literature, so literature is recommending to give some bolus and then you can start the sedative dose, but it's not good for the neurosurgical patient. So my preference is to start it somewhere between 0.5 mics per kg per hour, and then taper it down. So most of the time, so once you start taking your patient into the operating room, just start putting some monitoring stuff and start the infusion at low dose like 0.4 to 0.5 mics per kg per hour. You can increase it to up to 0.8, 0.9, and after 30 minutes you have to cut it down, so to depending upon the sedation level. So most of the time it has to be somewhere between 0.2 to 0.5 mics per kg per hour. It works very well.
Thank you, Dr. Faraz. The other question is with regards to Remizula and its comparison when it comes to other opioids which we are using during the case.
So to be honest, I don't have any idea of using remimezolam. So it's just a theoretical thing. So we have to see what sort of literature is coming. But yes, it has got beneficial effect in terms of, providing some analgesia and the sedation because of its rapid acting and the ultra elimination half-life. So I can't comment on it because I've never used it.
Okay. So Dr. Yasir wishes to ask how long a psychological assessment would be required, and are we involved? Do we involve psychologists as well before the cases?
So yes, as I've told you earlier, that neuropsychiatrist has to be a part of perioperative care plan. So neuropsychiatrist has to be there right from the start at the time of preoperative assessment. So once, so in the advanced healthcare setups, so what they do usually, so they select the patient for the technique. They start referring them to the anesthesia clinic and side by side to the neuropsychiatrist clinic also. So it's both. So both ways, they have to send us. So, but it's not available. But yes, if the facilities are available, so psychiatrist needs to be involved right from the start at the time of the preoperative assessment. And the neuropsychiatrist has to be there in the part of as a part of intraoperative neurological monitoring.
I believe the other question from Dr. Yasir, if there is any objective scale for psychological assessment, would have been covered in this answer. The third question would be how do we avoid pin insertion pain if it's not already covered by the scalp block?
So once you have done the scale block, it's important. It's like any other regional technique, you have to see the effect of your scale block. So most of the time, the distribution of the scalp is quite wide in terms of the nerve supply. So you have to see what sort of block, and it's also very important to discuss with your surgical team that where you are applying the pin and what would be your surgical incision. So if you think so, it really depends on your comfort level. So I think the better way of doing it, because again, there is a lot of intermingling of the nerves and the area of scalp is huge. So what my technique is to just put some local anesthetic. So ask the surgeon to apply Mayfield pin and just mark your points. And you can infiltrate some local anesthetic at those marks, like 1 to 2 ml of local anesthetic, and it provides absolute comfort to your patient. Patient would not feel anything.
Perfect, sir. So,
Excuse
yes, ma'am.
Dr. Lina here. Can I just ask? It was a very wonderful,
Yes. Oh, Dr. Lina.
enlightening presentation. I just little curious, want to know how long is this procedure? And being neuroanesthesia is pretty long, and to have the cooperation of the patient for such a long time, how do you manage?
So it really depends, Dr. Lina. Thanks for your comments. So most of the time, as I've told you earlier, that the selection process starts for a lesion having straightforward resection. So straightforward resection, and it also depends on the experience level of your surgical team. So for say if you think your surgeon is the expertise are not there, better not to proceed with the procedure. But yes, so depending upon the expertise of the surgeon, so I think this procedure should last. So most of the time it lasts for us by around 4 to 5 hours, starting from the
Oh,
injection of anesthesia to the end of the procedure in the recovery room. So for say
so it's
most of
quite
the time,
it's quite a test of patience for the patient as well as for the team, isn't it?
so yeah, it's like that. But by doing the preoperative assessment, by adding comfort to the in perioperative care of your patient, it's quite doable. So for say we'll most of the time we'll start our case at around 8, and by 12 or so we'll finish with it. So yes, but definitely the procedure has to take somewhere between good 4 to 5 hours. Yes.
And how expensive is this procedure as compared to the regular what we are doing?
So it really depends. So I think so the cost. So you can cut down the cost of the general anesthesia and the related stuff. But more importantly, by opting the technique, by improving the recovery profiles, you can cut down the special care stay of 1 day and the ward stay of 1 day. So you can reduce 2 days stay of the hospital. So it's also I didn't share the slide, but yes, most of the time and even in the Canada, in the advanced healthcare setups, patient the teams have start doing the as daycare awakenotomies. So you can see the
Yes, very
beneficial
good.
effect in terms of, improving the recovery profile. So and it all depends with the what kind of team you are working with. So for say, if you want to achieve the excellence, so in advanced, and believe me, in advanced healthcare setup, so most of the time working pattern is same like what we are doing. But yes, they are doing, as a daycare case.
So they must be using the navigation and the cortical mapping as well.
So it's an important part of it. So definitely navigation. One has to use the
Fortunately,
navigation
yes.
similarly, and definitely one has
And
to use the navigation and cortical mapping. It's the mainstay of the technique. Before I think, yes.
wonderful. It's the new way out. And my best of luck to the entire team. It was wonderful hearing from you people.
Thank you.
Thank you, Dr. Lina. So, Dr. Faraz, moving on to the other question. Dr. Yasir wishes to ask, how do we transit between deeper sedation for the skull opening, the the taking care of the dura, and the lateral sedation for mapping during the case? So,
I think
they would need to know the practical approach which we employ during our cases.
So I think you have to decide that what technique you are using. So for say, if you are doing it as an awake throughout approach, or what we call it as a conscious sedation, please don't. Don't use a sedation level where you have to step down your patient from a deeper sedation to a lighter sedation. So sedation level should be in a way that we don't want to lose the contact with our patient. Better to monitor your patient with the BIS or whatever sort of monitoring is available. Otherwise, you can monitor your patient clinically. But for these kind of cases, so what I would recommend, that patient should not lose the contact by having deep sedation. So I would not recommend, because most of the time, most painful aspect is the putting up the pins and the skin incision. So if you are doing the perfectly working scalp block, you don't want much sedation for a procedure. So you have added comfort, you have added Presidex. So there is no point that you fill up your patient with lot of sedation. I think it's not justified. So it's just my suggestion. So depending upon the technique, depending upon your confidence level, so I don't recommend giving much sedation at that point.
Thank you, sir. So the final question would be, are we using cerebral oximetry in our practices and during awake
No.
craniotomy?
So it's not available. It's not available, I think. So we are not using it even from the general anesthesia. So it's not available in Pakistan.
Thank you, Dr. Faraz. Dr. Lina had already added their comments. I would like to invite Dr. Khalid Shah from UK to share his experiences if at that part of the world they are well equipped with awake craniotomy and the practices are being incorporated. Dr. Khalid, please. I believe Dr. Khalid might be busy there. So we'd like to have Dr. Yasir from Saudi, if they can share their own practices. If they're in the Middle East, they have started awake craniotomy and the practices.
वालेकुम अस्सलाम वरहमतुल्लाह। डॉक्टर फराज, बहुत शुक्रिया आपका, बहुत अच्छी, बहुत नाइस प्रेजेंटेशन। हम लोग अपने सेटअप में इस वक्त यहाँ पे, जहाँ मैं इस वक्त awake craniotomy research पे
Dr.
कोई
Yasir,
experience नहीं है, लेकिन
Dr. Yasir, I just wish to request you, we can have the conversation in English because we have participants
okay.
who doesn't know Urdu as well here. Thank you.
I'm sorry. Thank you, Dr. Faraz. It's a wonderful presentation. It's very up-to-date knowledge. It's and great work you are doing there. In our setup right now, we are working currently in Riyadh. In my setup, still they are not started the awake craniotomy yet. We do not have yet any exposure to it. Whatever we gone through is through the literature and everything.
Can I say a few words?
Yes, Dr. Khalid, please. Thank you.
Oh, okay. I'm sorry, I couldn't find the unmute button. I was trying to do that. Excellent presentation. The flow and the contents were really very nice. So in my previous jobs, we used to do these awake craniotomies quite regularly in King Faisal and in King Fahad Medical Cities, two separate occasions. and of course, it's an evolving process. And we used to have the support of the neuronavigation team, neuro psychiatrists, and all those people that you would ideally have. So, and of course, the medications, all kind of medications were also available. So, having a simple kind of a practice where you do not have so much of a say in the context of a private practice or a private small hospital with a new service in Pakistan, I'm sure it will be very, very tricky. I'm really, really glad to see how Dr. Faraz and his team has been proceeding with this, and how they were to develop a significant practice. And I wish them all the best. And thank you so very much for inviting me and letting me say a few words. And really appreciate what great work you guys are doing there. All the best to you. Thank you.
Thank you, Dr. Shah. And thank you, Dr. Faraz. With this, we would be closing our session. I would request all the participants to fill in the feedback form provided in the chat box with the link, so that the e-certificates can be mailed to you afterwards. I would again thank Dr. Faraz, Dr. Asma, and the team who had also spoken here for their valuable remarks and comments. Thank you very much.
Sorry, I just want to have a comment.
Sure, sir.
So I'm just sharing the slide, so one can scan the code for the presentations related to neuroanesthesia and some online resources. So please scan the code, and you can have some updated literature and the relevant documents regarding neuroanesthesia, and especially the awake craniotomy. Besides, from the platform of Aga Khan University Hospital, we are going to have regular the neuroanesthesia online teaching forum. So it's on the Saturdays, where you can have some sort of the faculty lectures, case-based discussions, and the scenarios, or some sort of journal club. So it would be a regular activity from the platform of Aga Khan University Hospital. So I would request all of you to be a part of that discussion. And at that platform, anybody can come up with any idea, and anybody can have some sort of presentation, because it would be a more of the discussion forum to make to build up neuroanesthesia community. So please be a part of it. I'm sure you all must receive some sort of information related to that. And scan this code for this presentation and for the relevant neuroanesthesia stuff. So thank you.
Thank you so much, Dr. Faraz, for giving us time and for delivering this lecture. I would like to make another announcement that the next lecture, which was to be scheduled 2 weeks after this Monday, will be conducted next Monday because of the availability of the speaker, who is Dr. Arsalan Jamil, and that's on posterior fossa surgery. So I would request everybody that you would be getting the emails and the Zoom link connection very soon. And this is just a small announcement to be made. But again, thank you so very much, everybody, for coming online and for joining this lecture. And thank you, Dr. Faraz, for joining us today.
Thank you, Dr. Asma. So with this, we would be ending our presentation today. As a reminder, please fill in the link so that the certificates can be mailed to you guys. Thank you very much.